邊個係有一個你哋兩個都得喎，呢個會再深入係呢個長啲㗎，所以你呢個。多張佢去緊先6間咯。咁咧開咗個 cam 開啦。你應該記得攞翻個lunch box 俾冇話咩想食咩，冇帶除。Good afternoon, everyone. So let's give a warm welcome to Professor Ying Zhang. So good afternoon. We're very happy to have an old friend, Professor Ying Zhang, all the way from the Sheffield. Professor Ying Zhang. So I'm Dr. Jacqueline Chung, the acting chairlady of the department. And so today we will have her to give us a reproductive health seminar. So Professor Chung is a consultant gynecologist and fertility specialist with a strong clinical and research credentials. She trained at the Trinity College Dublin and completed specialist register training in Wessex and became a member of the RCOG in 2003. After earning a doctorate and advanced training in reproductive medicine and fertility surgery in Sheffield, she joined the University of Southampton in 2007. She co-leads the Southampton Fertility Unit with interest in endometriosis, recurrent miscarriage, PCOS, and adhesions. And she founded the Complete Fertility Southampton and also co-founded the spin-off Vivoplex and won a WISE Tech Award and leads research on embryo development and nutrition. And so today we are very happy to have her to give this talk on the precision reproduction, harnessing AI to predict, personalize, and optimize fertility treatments. So welcome, Professor Ying Zhang.
Thank you, Jacqueline. Good to be back. Many familiar faces. So I've been tasked to talk on AI, and I'm sure all of you here have some interaction with AI. Yeah? Yes. The DeepSeek. How many of you use it to do some work? Okay, so I'll try to do my best to try to tackle this topic today with you. Sorry, I'm just going to try to move this forward. Okay. So, question I have for you is, are you human? And before, we decide, someone seems to judge us by asking us to select all the squares with traffic light. Now, does that make us human? Is this what that differentiates us from machines today? Well, reproductive medicine was born of course, from Human Courage. We are all familiar with this nice photo of the past. It says, born of science, hope, and human courage. Science gave us the tools for IVF, ICSI, egg freezing, but behind every breakthrough was human vision, human fear, human hope. Huh? But now we stand at a new frontier, right? A future increasingly built not by pipettes, not by science anymore, but by algorithms and codes, huh? The black box. So the question isn't whether AI will change our field. It already is. You can feel it creeping in, can't you? The real question is, will we shape it or will it shape us? You just have to look around. These are just some of, the AI that's infiltrated our lives. And if we look a little bit deeper, maybe this is already out of date. Yeah, because the models and the algorithms have come out so quickly. The methods introduced, now we're talking about agentic AI, and AI that will try to reason and learn, right? So it is really not surprising that if trusting machines on decision that deeply matters can sometimes feel a little bit problematic, right? Now, HFEA very recently, this is late last year, so I'm a member of the scientific committee, and in authority minutes, there's this very nice figure. A little bit busy, but what it's trying to map out is the uses of AI in the patient pathway. So HFEA is the UK regulatory authority. And as you can see here, actually, it's not just for clinical treatment, if we're talking about reproductive medicine. It's not only about laboratory processes, but it's also around the ancillary processes around the treatment of patients, the clinical care. You're talking about initial engagement, talking about assistance with consultations, post-treatment uses, and of course, all the WhatsApp type chat features that helps us communicate with the patient. So that brings us to what I see as the big four questions that we, I suppose, what are trying to answer today. First, we talk about clinical support tools. Can we really trust them? There's also the question about data privacy and consent. Who owns that? That brings us into commercialization, the ownership and the power, and finally, of course, tackling the regulatory and ethical challenges. So let's look at the AI clinical support tools and what's out there. I think what I was going to try to do there is to describe 4 pit stops. From the first pit stop, ovarian stimulation, right through to embryo assessment and transfer. So let's look at controlled ovarian stimulation. So for those of us who treat patients with so-called controlled ovarian stimulation, or COS, short course, we sometimes feel, I don't know if you share the same feeling, that it may be not so controlled because there's this broad range that you see. Sometimes we just don't get it quite right? So would AI help with this inaccuracy, this sort of guesstimate we sometimes feel we're doing in terms of planning for our patients? Now, just take this fairly recent paper summary of what studies that looked at AI-based ovarian stimulation dosing solutions. So there's various different types. using large data from patients and then building models to see if it does or does not help. But what's important there, what I feel is lacking is actually the very obvious sort of outcome of interest and the lack of what matters most to patients, and this is the live birth rate. So here you can see in this particular paper, there were only 2 papers that really summarize the live birth rate. So if we were to critically appraise the outcomes as far as AI and ovarian stimulation is concerned, well, my feeling is it's not quite off the shelf ready yet. Why? Because these AI models, while they perform well, there are issues surrounding lack of external validation. So, if you look at all the studies thus far, there is perhaps a study or 2 that relates with some external validation, but significantly you'll find that most studies do not have that. And therefore, it impacts on the quality and the interpretability of these studies. And of course, we talked about the surrogate outcomes already. So pit stop number 2 brings us to ovulation trigger. Can AI help? Well, if we simulate a typical scan days here, right? So you can see, just drew some diagram of the follicles growing. Many of you will be familiar with this. When do you call the ideal time? Do you trigger here, for example? Would you, if you knew this was what will happen in 2 days? Do you trigger here if you knew that was going to happen in 2 days? Or do you trigger here if you knew what was going to happen in 2 days, right? We all have this experience. Oh, you should have triggered it a little bit earlier, but sometimes it's a lot of guesstimate, right? So would AI help? In a study that we took the opportunity to perform during COVID time, we asked 2 questions. How useful is control ovarian stimulation monitoring and assessing the timing of the final follicular trigger and the risk of over-response? This taking over 2,000 cycles, data from over 2,000 cycles. And the conclusion from that particular study using machine learning, and then it shows that the model performs with high precision from day 5 onwards. This has particular implications at that time, because this was during COVID, by reducing unnecessary scans for us and optimizing workflows. Furthermore, the removal of the baseline scans, which we tend to do, did not really influence the risk of OHSS. So it was very particularly useful during COVID times. We implemented it. And then retrospectively, we looked at the KPIs to ensure that it didn't change the outcomes for our KPI, and it didn't change our outcomes. And since then, of course, there are plenty of other studies that looked particularly at ovulation trigger. And you can see that there are various different types of models using different types of machine learning algorithms. But if we were to critically appraise these for ovulation trigger, for optimization, AI can identify a range of follicles size that best predict M2. Yes, we acknowledge that. But for clinical integration, it can be trained to assist with workflow. So scan days, workload, as you saw there is an example that I showed. But the key thing, however, is still we lack the validation that is required. And so I think this is very much future work, and I'm sure that will come in due course. Pit stop number 3 takes us to AI in gamete assessment. right? So what we're talking about here, we're talking about sperm selection, right? Faster and smarter, question mark, or oocyte assessment. So can the machine spot the winning egg better than we can? Okay. So let's look at the question around sperm assessment. A number of studies have used algorithms to assess sperm motility, morphology, DNA integrity, and even successfully isolate sperm from SSR samples in much lesser time than it would normally take. But we still do not have the technology that can select the so-called right sperm, right? So more recently, there's this study that has showed the first live birth from remote robotic ICSI. So this is using a system that automates all three. Somebody needs to answer the call. All 23 micro manipulation steps of ICSI. All right. And they use this particular system called SIT for tracking, which I'll show you in a video in a minute. They utilize laser immobilization to capture the sperm, and then it's a remote operation. So the actual operator is actually far, far away. Okay. And this is now applied to this. They've shown in this paper they successfully applied to this particular patient. 5 oocytes injected, good for 80% fertilization rate, blastocyst, and a live birth there. Okay, so this is the first example of a remote operator with an algorithm that captures and selects the sperm. And they've shown that the procedure takes 9 minutes, 56 seconds. The embryologists in the audience will go, oh my God, that's a long time to do all that. And it's acknowledged. So the authors had actually not say it's better than humans. What they've shown is proof of principle, right? So I don't know if any of you have watched this video, but has anybody seen it? So this is in RBM Online, and I've just increased the speed, so apologies if some of the words are really quick. So this is the SIT system where it picks out the sperm, and then so this is all remote operating. Imagine the next time you can do ICSI from your bedroom. David.
I'm just wondering.
Ah. Yes, the preparation of the dishes is not included.
Yes.
Yes. So whilst actually this is partial automation because the preparation of the dishes and there's various steps in there, the tweaking of certain machine is still reliant on humans. But what they've shown in principle is actually, it's possible, right? But it takes a long time. It takes 9 minutes. How long does it take you to do an ICSI?
What was that?
One.
Will be 90 seconds.
Oh, even faster, right?
Yeah.
Yeah. So this is all machine directed.
Ooh, wow.
So there you go. That's your ICSI done. Yeah. So I think in principle, this is coming and it's been shown definitely workable, but it still needs refining. But I still have a question because actually we still have the same old problem, which is which is the right sperm? The science is not there to allow the machine to pick because we still don't know how to select the best quality sperm, right? But in principle, this is now possible. Right. What about eggs? I think the story is similar. So with eggs, there are now multiple studies that show that using different machine learning algorithms, we're able to either select the best egg. You can see, in fact, some of these are already commercialized products. Some will even link that to the quality of the blastocyst, for example, and even looking at gene expression and predicting oocyte. So if we're going to look at the pros and cons, you can see here, I mean, I've listed it, right? Whilst it's proven feasibility, and it certainly would help if limited use of gametes and embryos are permitted by law. So in certain countries, that's the case. It is fairly fast. Most of these are split second, I can tell you. And so potentially improving fertility preservation care. But of course, the same old problem in terms of, being able to have the better gametes is not equal to the live birth question. And also, a lot of these technology hasn't really properly integrated into the workflow, right, of the lab. So whilst within their models, it seemed to have a certain accuracy that seems very promising, I think we still have to use it in the real world. And I'll show you in a bit some of the studies that potentially points out the problem here in terms of using it in the real world. So that brings us to the embryo selection and transfer question of whether AI can help. So would you trust an algorithm to choose your embryo? Now, some of these studies that I'm going to highlight. One of these studies, this is the first study I want to show you. And what this study did was looking at number of embryologists. Is that TikTok? Red book or red note or something, and different stages of embryo development. Technology they use is image segmentation, time lapse, or both clinical records, or both. And the AI algorithms, as you can see there, different types of image recognition algorithms, and some of them even integrate into the open source AI utilizing GoogleNet and ResNet as a format. And the output they're looking at is embryo morphology, aneuploidy, clinical pregnancy, live birth. Now, it's important that this particular study looks at all these studies to compare who is better, AI or the embryologist, but it uses a ground truth that only suits the clinic. So meaning they take the data out that the study's done, but in the clinic itself, right? So because the machine learning, the AI needs a ground truth, meaning what's the benchmark, right? And this particular study looks at that. So what did they find? So they say that using this retrospective data, AI is better than embryologists in selecting embryos. And you can see here why they say that. Well, bear in mind it's a retrospective study and you use ground truth from the clinic. And you look at images and clinical information, AI 81.5%, embryologist 51. Feel like tossing the coin. If it images alone, again, AI comes higher, score higher. Clinical information overall seems to be that AI, if you compare in this particular context, is better than the embryologist. Really? So this is a newer study just published not long ago. And this particular study is very interesting. It's a study from Massachusetts General. What it's trying to do is to try to see if these AI models are replicable. Is it stable? Is it reliable across the board? So they took 50 AI models, right? And just changed the start a little bit. Okay, because actually, if AI model is accurate, is precise, is reliable, changing the start a little bit doesn't make it worse. It should still perform. So that's what they did, right? And they tested it on over 1,000 patients, over 10,000 embryos, combined Cornell and Mass Gen. Same data, same architecture, tested across 2 IVF centers. What did they find? Well, first of all, they found poor agreement between models, right? So you can see there, the ranking consistency is low. The same embryos have different ranking. Secondly, the clinically unacceptable errors are quite high, right? So poor quality embryos that are obviously poor is ranked first, okay? And they found it contradicts all of the basic embryology practice. The third thing is the accuracy is misleading. So AUC curve 0.7, 0.6, but completely different decision-making reasoning. Okay. So all in all, the performance is really not stable, right? So why this matters, right? What is the issue here? Okay, what is the issue here? This is the prediction decision gap in AI embryo selection. Okay, so if we use the AI to optimize, say, a specific outcome, it will do that, right? It will do that. So the picture far left, right? But when you change the clinical context to ranking, so it's a different question that you're telling the AI to do, right? Which is better, how to rank? The model falls apart. It becomes unreliable. Okay. Does that make sense? So it doesn't appear like it's as good as what it should be when tested in the real world, in the clinical context of what we need it to do. And I think that brings us very nicely to this wonderful study that CUHK contributed to.
You too.
And David knows it well. And that is basically the RCT that was published in Lancet. And that's based on a fairly large population. And as you can see, the intervention group is those that has time lapse to assess the embryos with AI included, or no AI, an undisturbed culture still in the time lapse machine, and then conventional care. And you can see on your right, the difference in the live birth. There's no difference in the outcome, right? So when applied to the real world, it doesn't look like it's helping us, change the clinical outcome that matters. And actually, this is replicated through a few other RCTs, the Illingworth study in from Australia, UK, Europe, Kesslinger study, they all couldn't say that AI using these to select embryos are better. Okay, so we're down to reality check, the question around why. There are a multitude of reasons why AI models may not improve outcomes in the real world. The first issue relates to data, insufficient, inaccurate, or overfitting. Meaning, if you have a set of data and you tell the machine to learn from it, it can overlearn. So it will only fit in that set of data, which means that when you change things a little bit, it will give you completely wrong answers, right? So correlation is not causation, right? The risk is of exaggerating the bias because machines do not understand the causation factors. Okay, so when the clinical context changes, it would not be able to respond accordingly, unlike human beings. Okay, so they're not quite there, right? And the other issue, of course, is many of these models have not really been tested, integrated into clinical workflows. And that comes danger of you adopting one of these AI models into your clinic, tested somewhere else with an AUC that's pretty good, but actually doesn't really work in your clinic, right? For the multitude of reasons we talked about. Okay, so that's something I think we ought to be very aware of. But I feel the systems and methods are improving, and I think the trials are coming, and at one point it will be here, right? Now, what do patients think? Do we know we talked about all this about AI and we're all excited, but what do patients think about this technology? And there are two papers I can find that try to address this question. And actually, interestingly, they're fairly similar. Okay. This particular one is a US cohort. So patients know that what AI is. Everybody's using it, right? But actually, they have a fairly low trust of AI in healthcare. Letting machines think and decide on your care. I think we all feel a little bit apprehensive about that. There's a strong preference for clinicians, right? So if there's anything disagreeing, clinicians is always preferred in those scenarios. They don't feel safe allowing machines to say, this is the dose for you tomorrow, or this is where you need to trigger, right? Okay, a little bit more acceptance when it comes to selection of gametes. And when it comes to cost, it's interesting, this particular study, it actually highlights the fact that a lot of patients will not want to pay more just because you put AI in the system, right? Whereas you hear from commercial companies, well, there will be obvious cost to it and they're expensive. But actually, for this study, it borne out that patients do not want to pay, they don't feel they should pay. This is a European cohort, and again, over 200 fertility patients. Similar type of feeling is that there's not really certain about the benefit, right? And again, the sort of apprehension of allowing machines to do everything for them. The men seems to accept it a little bit better than women, but overall, the acceptance is still not there as far as the patients are concerned. So I feel that's very important when we look at technology. Whilst we're all enthusiastic, I think the patients also tell us something. So if they are not very, open to it, I think there is an issue about adoption, isn't it, of the technology. All right, so that brings us to the question around opportunity versus responsibility, efficiency versus humanity. Oh, that's a very deep question, isn't it? I think one of the biggest question I have in mind when you talk about AI is the data privacy and consent question. I feel, right? It's somewhere in the cloud, somewhere up there. Where, right? Whilst it's easy on your download to just press accept when these things come out, is it now, should we trust that with our embryos, right? So in Southampton, there's a very interesting project we're undertaking, which hopefully will answer some of these more difficult questions. So together with lawyers, AI engineers, and so on, we're tackling this problem by using the Social Foundation data model. So the Roberta project is a name we call this project. It's registered in the Jersey state. Jersey because it's used is a place that's used to dealing with wealth and trust, managing, stewarding, wealthy people's money and creating a trust to deal with that. So extending that concept a little bit, what we're trying to do here is to look at whether the data can be voluntarily donated. So this already exists in Jersey, where people can choose to donate their data voluntarily. Okay, and then there's a steward. So steward meaning those people who will legally be responsible for the trustee. All right, and then the use of this data for responsible research and so on and so forth. And we're going to do this. This study is not started, but it's been registered now with Jersey State. Few participants, and we're going to conduct some workshops to understand what Haitians think about donating data, generating data, donating data, reusing data, and then having a steward hold this responsibility. So the primary outcome eventually is to try to create a data trust blueprint, and this is hopefully then to be able to directly involve a legal trust, the instrument needed to establish a real-world data trust in the project. And then the second outcome would be actually to look at some of these data in this digital tool that we've created called PreCEMO, an app that provides psychological support that will allow patients to enter, on the app, and this will be captured. And in this particular project, it's a data trust project, but ultimately we're hoping to use the data to be able to help us with the research aspect of it. So I shall update you on how it goes in due course. But it is one of the models that I feel perhaps is a way forward for some areas of this data stewardship issue. So the next question we're trying to tackle, of course, is commercialization, ownership, and power. Question about equality, is it only the rich, if we charge, that will have the benefit? Is it fair? We already know healthcare is not fair in many ways, and there's disparities in access. For example, certain studies showing Black people have, worse outcomes already in IVF, for example, for various different reasons. All right, and I think that there are a multitude of solutions. I don't think we know for sure what works better for who, but these are some of the potential solutions that could exist where we have either open access or some sort of private-public partnership. And of course, at the bottom of that is cost-benefit transparency, right? Again, I don't have the answers for this, but it's something I think we need to think about. And last but not least is the regulatory and ethical challenges. And I sit in the HFEA scientific committee, and this question comes up again and again and again, right? How do we regulate AI in our field? How do we regulate? Right? Who's responsible? But if we look at the AI timeline, you can see that back in 2014-15, there was already machine learning models being published, being discussed. And then as we go to the 2015, 2020, more and more of these models, there's a deep learning models coming out. AI studies have started to come out. I think a lot of them on image associated, time-lapse associated studies. And then, of course, we are in the era of Gen AI explosion, right? I mean, Gen AI, but actually agentic AI now, even where, we can have little agents within the AI models telling us and learning, the processes so to modify these outcomes, whilst we're still, trying to do the studies and the trials. Where's the regulation? If you look at where the regulation is, it's really patchwork. It's very patchy, very fragmented, drafts everywhere. We still, do not have a firm regulatory framework. But I think that will come. I mean, EU, Asia, China, everywhere looking at specific frameworks for AI. And it'll be interesting to see how it will all pan out in the very near future, because we're going to have something very, very soon. So I think the crucial fact is that we are starting to ask the right questions and then attempting to solve them. And so here we are, experienced clinicians needing to think faster and deeper, not just can we use AI, but should we? And how should we guard trust, consent, and care in a world racing ahead of the rules? Okay. So in conclusion, dear friends, AI is here and we need to adapt fast, but not waver on our purpose as reproductive medicine specialists. We have to safeguard trust. So back to this traffic light question. We started today asking the simple question, are you human? I'm revisiting now in my concluding slide, not because we have picked the wrong squares, maybe sometimes we pick the wrong squares, but that I hope I have convinced you that AI will change how we practice reproductive medicine, and we will not be able to out-computer machines. However, it must never change why we practice reproductive medicine. So the answer to the first question is simple. Yes, we are human. We pick the right squares after all. We bring the humanity, and that is always going to be needed. Thank you.
So thank you, Ying, for your thought-provoking lecture, and especially let us how to rethink about the use of AI in the field of reproductive medicine, especially on your insights on the data privacy and also regulation. I think it really led us to rethink the use of it. So are there any questions from the floor related to AI and in the field? I also heard you have another previously. I remember from a previous talk you have this AI related Utron device that
yes.
was quite interesting as well.
Yeah. Yeah, I didn't want the talk to be too long, so I took that out because there were quite a few new studies that I wanted to include. So we have a tool that is a miniature uterine sensor that we insert into the uterus to detect oxygen, pH temperature. And of course, we're still doing trials on it. And the idea is we collect data and then try to integrate it with other monitoring that we all have now. People have earrings, rings, all sorts of patches everywhere. So I think the hope is that that data will contribute to future on informing how things change, say, for example, with lifestyle, with diet, or any intervention, what happens in the uterus. Yeah, so it's still work in progress because the clinical trials are still happening. So we'll get more data in due course.
So any questions from the students, maybe? Bea, you have any questions? Anything you want to ask? It's a good opportunity while she's here. Something or?
Stunned to silence.
Yeah.
Yeah, David.
So I'm sure about that. There are quite many AIs commonly approaching you
Yeah.
to test on their new products. But although I keep on I think the AI system still not clinically proof. But at your own opinion, how would you choose this company for collaboration? Do you have any specific criteria to let them in?
Yeah. Very good question because they're everywhere. They're everywhere. I think you look at the product and then do it as part of your research, right? I think the fear is if someone takes the product and use it clinically straight away. I think in a academic setting, it's an opportunity that pick one that you think fit the environment and then test it. Which actually is what a lot of these publications they do, and it is a good opportunity. But yeah, be wary that the external validation for a lot of them are insufficient. And if you are going to adopt them, I would use them and then see, test them properly in a proper design and see if it really is what it says on the tin. Yeah.
Thank
Yeah.
Any questions from the?
Yeah, there's a question at the back.
Yes.
Thank you very much for the good topic. It's quite interesting. I'm a neurologist, so it is quite interesting. And I have two quick questions. So the one is in our IVF center, we often see in the very severe oligospermia. And since like 10 years ago, my hope is that one day that very nice AI can find this tiny number of sperm, and we don't need to work too hard. So do you have any idea to be detected in a thesis sperm? So this is the first question. And the second question is, you mentioned about the trigger, right? The trigger.
Trigger, yeah.
OP1.
Yeah.
So I want to know that our clinic clinician choosing the 2 or 3 different trigger depend on the patient. So like this kind of system can choosing the trigger medication itself as well, or is it only we can put in the one trigger, actually only one medication, and then they will choose the timing. So this is the question.
Okay, so the difficult finding sperm thing, there is, I don't show the paper, but there is a paper that has already shown that it's very much faster for the machine to find the sperm. So I think that is indeed one of the areas that would really become very useful, because I remember, and I'm sure all of you have experienced, 2-3 hours, the embryologist is trying to look for the sperm, and finally they find one and everybody cheer, right? Yeah. So I think that would be an area that machine robotics will come in. The second question is about trigger. So the current AI models for trigger are more to do with the days of trigger, right? What they'll say, for example, one of the A-Live machine learning software will say if you trigger, they use large number of data and the machine learns from it, and then they will suggest to the clinician, oh, you should trigger here on this day to get the maximum M2s, right? But again, the external validation is what it is, right? But it doesn't, I don't think, it hasn't evaluated whether you should be using what specific medication. But I think for clinicians, the two important triggers that will make a difference. One is to decide whether you're going to use an agonist trigger. Okay, but there's a specific clinical condition where you would want to use an agonist trigger, so the risk of hyperstimulation is high, yeah, and you're not planning for fresh embryo transfer, right? The other is ACG, which is your usual trigger, but I don't think any of these softwares tell you what medication to use. It's more to do with which day is the best day for trigger, yeah. So I don't know if that answers your question. Does that answer your question?
Yeah, it's fine. And sometimes you feel like a trigger, it doesn't match it to the patient. And we have in AI and we can choose in the best trigger and time and the portion. And we are affected to the mature oocyte number. So it will be more ideal.
Yeah. So just to give you an example, right? If the model used to train this best day of trigger does not recognize the clinical characteristics, one scenario that it might completely do the wrong thing is, for example, in your hypo patient. So these patients do not have ability to secrete any LH or anything. So if you give them an agonist trigger, it's not going to work. You get 0 eggs, right? So those models will have to have that information, or a person will have to pick those up. Or, for example, if they are on an agonist protocol, long protocol, you can't use agonist trigger. So I think that may be a little bit difficult until the models are so much more intelligent that they can actually grab the clinical characteristics, i.e., which protocol the clinician had put in, and compute that. I think we're several steps away yet. Yeah.
So, are there any other questions? Abhi? Yeah.
Thank you for your presentation. And I would like to ask a question about prediction success target model. So because it's very important for consultant for the IVF patient, and we should let them how many percentage of success rate. So for some clinical prediction, do you think should we apply for consultation? And what do you think about some clinical paper they published about a prediction model, whether live birth or like in IVF or IUI?
So let me see if I got your question correct. So you're asking if these prediction models that tell you the prognosis of the patient. So if you enter age 42, 3 cycles of IVF, and it gives you a number there. I think those models exist for a very long time already, and all they do is use large amount of data to generate a statistical model to give you a chance, the odds of success. Yeah. So it is interesting because those will differ depending on the population of what data you feed in, you know? So for example, if you use a UK model, right, from Scotland, right, even though there's a huge amount of data, that will pertain to UK alone, you know? And then if you use a US one, it would be, so I think we have to be aware of that, even though, of course, it gives us a generic guess estimate of the range of where the success is. So they're fairly, I think, accurate. I mean, as a guide. It's not a specific, it has to be this percentage, but it's as a guide. So if you're punching in the information for your patient and advising them on a prognosis, I think it's a reasonable model to use if you're using that. So I use a lot, I use the HFEA model for our patients because it's a UK population, right? But of course, if you do a lot of PGTA, yeah, American physician, then maybe it's not as accurate for you because of the use of PGTA and so on. So I think it needs to be applied to your population. Yeah.
Okay, thank you.
Sure. Thank you, Dr. Chen, for your sharing. So, from what you've presented, I think like for the prediction wise, probably we still have a bit of way to go. But then, I want to ask like going back to some like easier stuff for AI, for example, like doing a semen analysis. So, is there any like currently commercially available models, like for example, looking at like fertilizations, because those with that might help with our embryologist work. Like that you're aware that are currently already like proven or in use, those models.
No, none doesn't exist in short, right, David? You agree?
Things analysis, yeah, they've got some AI system, yeah, but it makes no difference for the embryologist.
Yeah, because I'm seeing like AI is like an assistant tool for our embryologists, because in future, some jobs might be replaced by AI.
Yeah,
But probably we're still not there yet.
They're not going to replace me anyway.
Well, it's like anything in technology, isn't it? Industrial revolution, you have, people will learn new skills, right? And you would not